Thank you for joining us for the SBIRT in Action, another vital sign webinar. This is being presented by Dr. Ronald Dwinells, MD. He's a pediatrician who has served since 1998 as the Chief Executive Officer at the Ohio Northeast Health System, located in Northeast Ohio. He is a frequent speaker on national level discussing topics of health disparities, healthcare leadership, and healthcare administration. I would like to present Dr. Dwinells to you now.
Well, hello everyone. This is my first time doing a webinar, so may feel a little awkward to me because I'm used to seeing people's eyes and body language and so forth, and that cues me into knowing whether I'm being bored or I'm being boring or not boring. So anyway, please bear with me if I don't come across to your needs. But anyway, yes, I did entitle this Another Vital Sign because I feel that SBIRT is a form of vital sign, no different than taking a blood pressure or respiratory rate or heart rate. I think it's a vital sign for your behavioral health, your mental health status, and so forth. So that's why I named this, and that's actually the way we quote sell it to our patients. I do want to make a couple of disclosures first. As you saw, I am a pediatrician by education and training, and not a psychologist or psychiatrist or behavioral health worker or social worker or any of those. I have a personal interest in behavioral health, and I think it's intriguing. And I also have a professional interest from the perspective that I am a CEO of an organization, and I do want to improve our rate of understanding and identifying and treating folks who have behavioral health problems. Just before we start, and again, I'm not 100% versed in a lot of your folks' terms, so in my world and in my mind, when I talk about behavioral health, I'm talking about both mental health illness and substance abuse types of issues, such as alcohol dependency or drug abuse. And then comorbidity, in this reference, I want to use comorbidity defined as both having a physical health problem as well as a behavioral health problem. So that's just so that we can all be on the same page. So before I start with the formal slides, Chris, can we do the first poll?
Okay, I can only have so many characters in these questions, so let me read the full question to you. If you believe the healthcare system is not adequate as it relates to behavioral health issues, please indicate where you think the breakdown is. We do not diagnose patients with behavioral health issues in a clinical setting adequately. We do not treat or manage them adequately. We do not have the capacity and/or resources to take care of our behavioral health patients adequately, all of the above, and I do not believe we have an inadequate healthcare system as it relates to behavioral health problems. Okay, I'm going to close the poll now. It looks like we have a pretty good representation, and then I'll share the results with everybody. Okay, 3% of the people say that they think that we do not diagnose patients with behavioral health issues in a clinical setting adequately. Another 3% say we don't manage them adequately.
health records, and they are automatically scored by that. So we can actually track and follow the scores. And that's the other thing that we've been wanting, or not been wanting, but we are doing is, again, every time a patient comes in, we are doing these SBIRT study or SBIRT tests, and therefore we can track the scores as we go on. So theoretically, I guess in an ideal world type of thing, if a person has been in 5 times in a year, we will know the score of each visit, and then we can see if the interventions or the talks or whatever has improved those scores over time. So, but yes, I made it a long-winded answer, but yes, the answer is yes, we do have electronic health records, and I think it would be very difficult to do this without the electronic health records. Obviously, it's possible, but this makes it so much easier. We can track all kinds of data with it.
Here's one last one. How many hours of training did you provide your clinicians?
I can't remember total. The way we did it over at the Youngstown site is we had again, I sent all the providers and all the clinical staff workers to the SBIRT training. And again, I can't remember how many hours that was, but I do know it was more than 3. And then we had some internal in-services that I did, and then we also had some training on interviewing techniques and so forth. So I would say if I estimated the cost, my CFO isn't here with me because she knows all those numbers, but I would say probably no more than 5 to 6 hours total if you put it all together.
Do you know if there are any changes expected in reimbursement so providers can have some incentive to intervene early?
No, I don't. Again, you know, we in Ohio don't get that, but my suspicion from an administrative perspective and trying to figure out what's going on with our whole health delivery program in this country, I'm thinking that things like our medical organizations being involved in patient-centered medical homes, the health homes and so forth, I believe that future reimbursement is tied into those status, if you are PCMH certified and home health certified and so forth. And if reimbursements are tied into that, obviously these types of exercises and these types of efforts I would assume would go a long ways in terms of having some effect on indirect reimbursements, if that makes sense. But directly, I don't. Again, in Ohio, we don't have any experience in that sort of thing.
Okay, and I have one last question, and then if you don't mind, I'll go do a couple poll questions.
Okay.
We are only getting about 3% positive screens from the audit and DAST. I am interested in how our processes differ.
Yeah, I don't know. Again, you know, our process is, again, I don't know that particular person's setup, but we are screening every single patient with every single visit. Maybe that's the difference. Maybe one time they come in and they're not going to answer positive. Maybe the next time they do. I don't know. That's hard to say why there's such a discrepancy in the numbers. Again, the other part is the pre-screening is self-administered. I don't know, again, how this is done in this questionnaires process, but if somebody else administers it for them, some patients may not want to say. I don't know. It's hard to say, so I can't really answer that particular question at this point. I don't know. I would have to know and understand that person's process.
Okay, thanks. We're going to just take a brief break now in order to ask you a couple questions. We want to find out more about you as our audience. So these are just another quick polls here. We want to know, what is your current professional role? Are you a counselor, therapist, social worker? Are you a nurse or nurse practitioner, physician or physician assistant, a program or unit administrator, university student or faculty, or other? And if you are other and want us to know what that is, excuse me, you can send your answer in a chat or in the questions box, so we have that. Okay, so for the first poll, 44% of the attendees are counselors, therapists, social workers, or caseworkers. We have 14% who are nurse practitioners, physicians, or physician's assistant. 9% program or unit administrators, 7% university student faculty, and 26% other.
Chris, this is Holly. We did have some people indicate we have a physician in internal medicine and program director, a research scientist, and they're answering, a psychologist. They're answering in the questions tab.
Okay, thanks.
Thank you guys for participating.
This is, what field do you represent? Medical health, or I'm sorry, mental health, addictions, physical health, education, or EAP? So what's your basic field? Okay, so for this, in addition to the people that Holly noted, 27% are here from mental health, 43% from addictions, 8% physical health, and 22% education, and nobody's attending from an EAP. So thank you for that. And I've got two more real quick ones. These are just quick yes, no. Do you currently conduct SBIRT interventions in your facility? So far, 60% do not conduct SBIRT right now, and 40% do. And then for our last question, do you see your agency using SBIRT in the future if they don't already now? Yes or no? Okay, well, there's a real quick answer here. I'll just close this now since it's pretty obvious here. 94% of the attendees feel that their agency is or will be using SBIRT in the future, and 6% don't expect that to happen. So thank you all very much for participating in this. Dr. Dwinells, I'll turn it back to you now. Thank you.
Okay. Thanks, Chris. That was very interesting. So it looks like I'm predominantly speaking to counselors, social workers, and so forth, right?
Yes.
So anyway, after getting some of this, again, I'm taking on this journey of mine where I'm trying to learn and understand this and trying to do something with my organization about it. So what is the solution here? And obviously we go back to that one professor's comment from OSU. Let's be proactive and ask our medical patients if they've got a problem. It appears to me with these preliminary numbers, that 6-month test period, that number one, patients do want to tell us that they have a problem, and number two, once we find it, some of it doesn't seem like we're doing a whole lot about it. So that's a real problem. But anyway, so when we started our SBIRT application, our goals was first we wanted to improve our identification rate. Again, we go back to that slide I showed three, 4 times now. Our rate of diagnosis was really poor. Well, mind you, the term identification and diagnosis here are two different things. So first of all, we have a 63.3% identification rate, but they're not all being officially diagnosed, and there's a lot of reasons for it. They may not really meet the criteria. They may just have the propensity for that, or the doctors or the providers may not feel totally comfortable with making committing to paper that particular diagnosis. So, but we wanted to improve our identification rate of our medical patients who have behavioral health issues. And then once we identify them, because to me that's the first step, is you got to know to be able to do something. We wanted to increase our level of involvement through intervention, treatment, or referral, and obviously all that fits into the SBIRT model. So again, we did this as a research project, a clinical research project, because I wanted to prove some points, especially to our providers, but yet I wanted to be able to share our data with my colleagues out there to show that, hey, you know what, this is good stuff. So our alternative hypothesis, if you all remember your statistics, is we felt that the rate of diagnosis, intervention, and referral for behavioral health issues will increase by administering a behavioral health questionnaire to all medical patients with every medical visit. And that's pretty much summarizes what I've been talking about earlier. So this is our diagnostic rate during the test period. So this in blue here, this was our behavioral health diagnosis in 2012 during that exact 6-month time period from March to August. So we didn't want any kind of external things messing up our data, so we didn't do it in the winter months, or we didn't do it in the fall months or summer months or whatever, but we went with the exact same time period of February to August 2012. So we looked at the data there, and we had 330 people that had official behavioral health diagnosis. During the same period in 2012 or 2013, during our test period this is Youngstown Community Health Center, we had 627, which is a 90% increase in the diagnostic rate. So that pretty much tells you that that exercise of providing SBIRT was effective. It improved the awareness of our providers, and therefore I believe that that in turn improved the diagnosis. At our control site, and this is Warren West, during the exact same time period in 2012, it was 186 diagnosis, and then during the test period, analogous to this test period here, we had 192 for an increase of 3.23%. And again, I think some of you who are very knowledgeable about statistics, there's a concept called confounding variables, which means that just by talking about it, because I've talked about this in our organizational meetings, I've talked about it one-on-one with our various doctors at all of our sites, but I didn't officially implement it here. I implemented here, but I think these confounding variables might attribute to the slight increase in the diagnostic rate. But obviously, this is statistically significant. We have a 90% increase here compared to 3.23% here, where we didn't do anything. So the time question, everybody asked about the time question. So we had 2 doctors involved at our Youngstown site. So in 2012, and again, we looked at the same time period, an average, it took 1 hour 40 minutes for a patient to get through our clinic in Youngstown. And that included from the time into the door until they were exited by the front desk personnel. So the whole process, on the average, took 1 hour 40 minutes for this Dr. S. During the test period, it took 1 hour 45 minutes. So there was a 5-minute increase. And again, this isn't super scientific, but really the main variability here is the addition of the SBIRT process in the whole clinical scheme of things. So Dr. K here had an average of 1 hour 44 minutes during the analogous 1 year ago period, and then it's 1 hour 29 minutes during the SBIRT period. Well, we don't know why there was a significant decrease here, but to me, what I take away from this is there was no negligible increase in time, and I think that's a really important concept to make. I've shared this data with my providers, and intuitively they agree. they say, you know what, I agree, it hasn't really taken that much time with the process that we've developed. So anyway, I think that's what we can come out of this. The end number in this statistical analysis is, again, 2,482, I believe, with this. And then this was similar numbers. So anyway, this is, to me, this was very eye-opening. The referral process is really, really interesting because here we go again with the back-end problems. So what we looked at was during a 12-month period in 2012 at the Youngstown site and the same 12-month period at Warren West in 2012, this was the breakdown in terms of referrals. So, and I'm not going to go over every number, but just to get us started, for depression, we had 48 referrals made in all of 2012. We looked at the intensity of the referral rates. So this number just measures more or less intensity. We wanted to know what was the percent of referrals to the total visits during that time period, and it was 0.7%. So 0.7% of our patients were being referred for depression. There were 10 people out of this 48 that kept the referrals for around 21% kept referral rate. Okay, and then you can see the same thing for alcohol and drugs, but no one kept their referrals, but we only had one referral. So again, I go back to the sarcastic remark to my staff, boy, we got a really healthy population in Youngstown. So here's Warren West, the control. Pretty similar numbers. We only had 26 referrals here for an intensity visit of 0.3%, 0.43%, and then only a 15% kept rate. But again, here, no one kept their alcohol and drug appointments, but we only had one. So anyway, to me, this is pretty dismal. Okay, so here is our comparison during the test period, again, February through August. So now we have 97 referrals in a 6-month period. Again, that's compared to a 12-month period here. So in 6 months, we doubled the whole year's referral of depression to 97. And look at the intensity. It's 3.51%. So again, this goes back to that whole concept of awareness. We're identifying people, and we're more aware. 30 kept their appointments. So our referral kept rate improved a little bit by about 10%. So, so it seemed like it has the SBIRT process has some bearings there. Because again, remember, this SBIRT did not affect just the providers, it affects the whole staff down there. So everybody becomes aware of this. At our control site, a little bit better than last year's. Again, I'm going to attribute that to these confounding variables, but our referral kept rate was 17.65% compared to 15%. So those numbers are pretty similar. But look at the alcohol and drug referral kept. So we did make a significant improvement in referring our alcohol and drug folks, but nobody keeps their appointment. 0% at our test site as well as our control site. And the way we know this is we had our referral clerks call the referred agencies to see if they kept their appointments or if they didn't keep their appointments. And so this to me was very, very eye-opening and very interesting. And I think what this does for me is it makes the case for the so-called integrative healthcare model. If we were able to do the warm handoffs, if we had behavioral health workers on site or readily available, we could walk them over right then and there. And when I talked with the referral clerks, they said that the average appointment lag time from the time that we requested an appointment to the time they had the appointment was about 2 to 3 weeks. So, yeah, 2 to 3 weeks, they're not going to keep it. And to me, it's always better to take action at that point in time when you got them in your building, when you just saw them, and they just answer these questions, and the providers talk to them. It would be great if we could just get them over to the behavioral health person right then and there. But I think that this makes the case for this integrative health model that I think is just around the corner, hopefully. Intervention analysis. We couldn't really do a whole lot of intervention analysis because we don't really have anything to compare it with. There's not a place. We had to build it into our EHR, the intervention documentation locations, but so we didn't really have anything to compare this with last year or with a control site, but we did make some interventions here, and again, by itself, it doesn't really mean a whole lot except for the fact that we are making, we made 869 interventions out of that 2,400 people that we did do the SBIRT on. So I forget if there were any. I think there were some administrators, 9%, I believe, on the call here. So this was our startup cost. This was it. And that's all there was to it. We spent some time training for SBIRT, some motivational interviewing training, and so forth. And that's all we deemed as our cost. And it's when you broke it down. And again, this is just at one site. It was $731.01. Our CFO told me to make sure I put the 1 cent here. Our paper supplies, you know, for the SBIRT pre-screening was done on paper, so that was given at the front desk. So the paper supplies cost around $35, and so our total startup cost was $766.01. I didn't put my time in there. That would have tripled this. No, I'm just kidding. But anyway, the point about this slide is it's minimal cost. Of course, there's always case stories. I have lots of them, but just a couple of illustrations here. Just recently, one of our nurse practitioners told me a story about this lady who came in with significantly severe respiratory distress. She was in really, really bad shape. They gave her aerosols, and they stabilized her, and she was doing really well after about an hour, and they were going to discharge her. But right before they discharged her, the nurse practitioner looked at her SBIRT scores and her PHQ-9, and she was at a very high level, and she was actually suicidal at that moment in time. And the nurse practitioner told me that she said, you know, I would never have even thought, I was so focused on managing this respiratory problem that I would have never thought to ask about any type of behavioral thing. And when I saw that, I was stunned, and I went and explored that with her, and then we did get her some help, and she said, I think she would have committed suicide that night if we didn't help her. So, you know, that's one of many, many stories that we've gotten since we started this. Again, you know, as they say, the teeth is not separated from the body, the mind is, and I don't think behavioral health issues are separate from physical problems. We all know that there's a lot of comorbid conditions. The drinking problem pregnant patient is where this lady comes in and she's diagnosed with pregnancy, and they do the pregnancy workup, and you know, they were going to go ahead and do the usual referrals to OB and so forth, and it turns out that her SBIRT and her DAST indicated that she had a pretty significant drinking problem. So you know, so that was at least identified, and she was talked to, and so forth. I don't know if she was referred, but obviously if she was referred, she didn't go, because we know that there's a 0% rate of alcohol types of people going to their appointments for referral. But anyway, the point here is that obviously drinking and being pregnant don't go hand in hand, and you know, so hopefully we were able to save this person's baby from any type of anomalies and distress and so forth. So anyway, and again, there's many, many more stories to this. I think for me, and I'll just share this, it's a personal story. I told you at the beginning that my interest stems from personal experience. My dad was a longtime military person. He was a career military guy, and in 1966 he had 21 years in, and he was early in the year he was had orders to be deployed for Vietnam, and he didn't really want to go. He was I think he just, well, in 66 he just turned 40. He didn't want to go, and so forth. And then later in the year, or a couple of weeks later, I guess, he was diagnosed with diabetes. Well, his love in his life was cooking. He loved cooking, and he made great foods, and that was his passion. But the problem was he loved eating too, and so he did gain weight, considerable weight over time, and I believe that's what set off the diabetes. And anyway, so he decided to retire from the military. Well, the Army was his love too. He'd been in the Army, since he was very young, and but he could retire. He had enough years to retire, so he retired, and then he had to curb his diet. Well, those are two passions that he had, and so over time, whenever he went to the doctors, the focus was on his blood sugar and his weight. But no one ever asked him, how are you doing? How do you feel? Are you okay? And what was happening was, all along, he was getting depressed because he couldn't practice his passion anymore. So as time went on, he got more and more depressed, and the more depressed he got, the more his diabetes got out of control, and his sugar levels would go up, and everybody would yell at him, my mom, the doctors, and so forth. And so his depression got worse, and the more his depression got worse, the more his diabetes got worse, and it was this this back and forth thing. Well, he ended up committing suicide. He was so depressed, he just couldn't deal with it. Well, back then, and even now, we don't do that. We're not asking, as medical providers, we're not asking these people, do you have a problem? And I think that's a problem for us. We're not identifying, and as physicians, as medical practitioners, we should be asking. That's part of the medical delivery system. We as doctors, I believe, it is our responsibility to do this. So anyway, and I think you all have probably myriads of stories that you can share like this. But to me, this is a great start doing this SBIRT, and and I think it makes sense. And some of our preliminary data shows that it is saving lives. So for that $736 that it cost us, we actually have saved lives. And in my world, if you save one life, then you've done a lot in a lifetime. So anyway, so I'm to the question and comments section again. So please, if there's any questions, comments, please ask. So,
yes, I do have a few.
Okay.
Let's see here. World Health Organization reports 75% of population is low risk for abuse or dependence issues. Would you expect to see 25% positive screens over enough time?
Probably. I guess I would statistically, if on a very large scale that was the ratio, then I would expect so. Now, just as a background, our organization is an FQHC, a federally certified health center, and our mission is to provide health care to the medically uninsured, underserved, underinsured population. So they are more of the poor, the poverty-stricken types of folks. I believe, and again, I don't have any of my references with me, but I believe that I've read where different population segments tend to have different rates of substance abuse and drug drug addiction and so forth. And I believe in our population it may be a higher rate. And again, I don't have those references in front of me, but so I guess my point is that we may expect a higher rate. And again, the whole exercise here to me is that that we historically have not done a very good job identifying who these people are, and I believe this whole process does help us identify them and to be able to do interventions in a more timely and appropriate manner. I'm not sure if I really answered that question adequately, but that's kind of off the top of my head is what I'm thinking.
Mm-hmm. Okay. And I'm going to unmute Kara here. She has a question about referrals.
Okay, great.
Okay. Kara?
Hi there.
Yes.
I really appreciate you showing the key points of the SBIRT process. And one of the things that we've found at our site is that we have very few people who are referred to treatment actually utilizing that referral. And we contact them within 48 hours to schedule an appointment for a more in-depth intake or start treatment. So we feel like we do have a reasonably warm handoff and quick turnaround of trying to engage that person, but unless there's any kind of court involvement or employer involvement, it is hard to get somebody to kind of all of a sudden be told that they have an alcohol problem and that they're not expected to kind of take ownership and action for it. So I just didn't know if you had any other experience with sites that had kind of successful strategies for converting referrals into treatment patients.
Some of it was muffled coming across, but I think I got most of what you were saying, Kara. You know, we wanted to see the raw data first before we put anything, the so-called artificial types of things in, like having coaches and calling them back. We wanted to see what they were doing without any kind of interventions from that perspective, where we're aiding their referral process. Yeah, and that's why we only did it for 6 months, because once we got the data, then we can go to the next step, which would be, hey, we got a real problem with our referral kept rates. So what we're doing is we're in the process of looking at creating a behavioral, well, there's several processes going on. One is creating a behavioral health model where we have behavioral health workers on site. I read an article once, there's a group, I believe it's an FQHC out in Colorado, who does this, who have embedded behavioral health workers in the clinical setting. I think that makes a lot of sense, and I think that's what we want to get to. And that way we would do the warm handoffs. Yeah, I think the 48 calling back, the 48 hours is a great idea type of thing too. We haven't really looked at that part. The other thing is we are working with our local behavioral health care partners to create true integration and co-location types of settings. In fact, at one of our sites, we're looking at relocating our entire clinical program to a site about a tenth of a mile as the crow flies from our current location to a location where there's a adult behavioral health organization on one side and a pediatric behavioral health organization on another side, and there's a strip of land available in the middle. And we want to build a new site there and have a true co-location, true integrative healthcare service. But I think the key here is I think, again, going back to that warm handoff, holding their hands and taking them there and doing it real time, the real-time interventions, the real-time referrals, I think is going to be the answer, because I don't think, let's face it, a lot of these folks cannot be responsible for themselves. They're sick, and to expect them to be responsible to keep appointments 2 or 3 weeks later, I don't think it's going to occur. And obviously it doesn't with our data. It's showing that they're not going to keep it. And when I talk to my behavioral health care partners in our area, they all concur, yeah, it's not going to happen. So I don't know, Kara. Again, it came across somewhat muffled on this side, but did I answer or make the appropriate comments to your question?
Kara, do you need any more information? Well, I guess she must be okay, because she hasn't emailed back. Okay, here's another question. Are you doing SBIRT with your child and adolescent patients?
No, not at this point. Our plan was we would start with the 18 and older group at the beginning. Again, we tested it at the Youngstown site. We're in the middle of spreading it now, so we spread it to our other sites, only in medical at this point, and only those 18 and older. Our next step is going to be dental. We've been working through the logistics of doing SBIRT to the dental program. Part of the reason is half of our patients are dental patients, and then half of those dental patients are medical patients. So that means we're missing 25% of screening of our total patient population. So we felt that it was really important that we get to the dental as soon as we can. So our plan is, starting in January, we're going to spread it to our dental patients, and then the third phase, hopefully by next summer, we can start the kids. We operate 2 strictly pediatric sites, and that's where we'll start it. One of the reasons we didn't start with peds is because it's a little bit encumbering because of the patients or the parents' approval of us doing those things, and you have to go through the parents, and sometimes the parents don't want you to ask their kids, teenage kids, these questions and so forth. So we're still kind of working out the logistics on there. The pediatric behavioral health site that I was telling you about have started their SBIRT at their location. So we're going to try to learn from them too before we implement it in the peds side. So it's kind of a phased type of thing. So 18 and older first, the dental patients, and then the peds patients.
Okay. Have you had any success in getting patients who are not alcohol or drug dependent, but who are drinking at high risk levels, to cut down on their drinking and or drug use as a result of the brief intervention by a provider?
Yes, and I don't have the firm data, and that's why I didn't present it. But looking at it, as you may recall, I talked about looking at serial SBIRT scores, the serial scores of the DAST and the audit and so forth. And preliminary findings show that it is improving. And some of these interventions are simply where the doc or the provider just talks to them, and so they're not like full blown out type of interventions where they're making these heavy-duty referrals or anything like that. So, but looking at the serial scores of specifically the DAST and the audit and the PHQ-9, it does look like there's a trend of improvement. So I do believe that, to answer this question, I do believe that the SBIRT process is helping with the with those people that have those problems.
Have you gone to places to train SBIRT, or would you be willing to go and do that?
Yeah. I've done a couple of local lectures. There's a local organization called Neil Kennedy up in Youngstown, and they're very active. In fact, that's where I first learned of SBIRT. Doug Wentz and Jerry Carter, if you're on this call, kudos to you. But they introduced me to SBIRT, and they have regular SBIRT training up there. So I have done some lectures on that. I think Doug asked me to do something down in Columbus. But yeah, I believe in this so much, especially with the data now, and then again with my personal experience, that I'm advocating that that this happens. In fact, I have some other things. I think I have just a couple more slides, which kind of goes into this. But some of the conclusions here with SBIRT is, we are, the whole staff, it's just not the doctors or the nurse practitioners, it's everybody. We're all aware now that, hey, there's a lot of people with these problems, and I showed you that our diagnostic rates have improved. Our patients don't have a problem. There's a little bit of a myth out there that patients won't tell us, but they will. They don't have a problem disclosing these behavioral health issues. And the time commitment is minimal, as you can see, and that's 6 months worth with a significant amount of data, and we didn't see an increase in time commitment here. And there is minimal startup cost for what we did. I suppose you could do something a little bit more fancier, but we didn't have to really do a whole lot to start this up. And we do know that patients don't go to referrals, and we know that medical providers are not too good with it. The nurse practitioners are far better than the docs on this, and I don't mean to beat up on the docs because I am one, but I'm going to tell you that the nurse practitioners are much more aware. I think they're more holistic-minded anyway. And then again, SBIRT can save lives. So I don't mean to be long-winded here, but that's, yes, I am willing to do anything that I can to help somebody. And please, if anybody has any one-on-one questions or one-on-one questions, please call me. I don't know if my contacts information is out for you.
Well, they can email us and we can forward those to you.
Okay.
I know we're right at the end here, but I've got 2 more questions.
Okay.
Can you answer them?
Yes.
Okay. Do you have a referral list available with agencies that are aware of your study, or do you have some of those services available within your health agency on an appointment basis?
Yes, we for 2 years in a row now, our organization hosted a summit, and where we invited all the behavioral health organizations within two of our biggest counties to be involved, and the participation rate was, I believe, almost 100%. But so yes, everyone is aware of our study, our work, and so forth. And one of the things that came up in the last summit was there's barriers that occur when we make referrals to behavioral health, and I believe there's barriers coming back to us. So one of the big barriers is a lot of our local behavioral health organizations want us to let the patients make the appointment and not us. So in other words, the patient becomes responsible for making the appointment and getting there, and that becomes a real barrier because most patients won't call or won't do that. And I understand from the behavioral health side why that's done, but we are meeting with various organizations to try to work through that. So Chris, I can't remember the other part of the question. That was the list.
Yeah, it's just, do you have list of referrals available or someplace in-house that you can refer them to?
Yes, yes. And I think the other part of the question was, do we have anything internal? And I mentioned Neil Kennedy before, but Neil Kennedy has been gracious enough to have a behavioral health worker 20 hours a week at our site. She's not a licensed independent social worker or anything like that, but she has behavioral health work experience, and I think that's helped. But the 20 hours is a real detriment. That's better than nothing, but it seems like, just like anything else, it seems like a lot of these patients tend to come when she's not there. So, but it just amplifies or promotes the idea that we do need in-house behavioral health types of folks.
Mm-hmm. Okay. And then it looks like just one other question and a comment.
Okay.
Do you have to complete GPRAs for your screens? Is your clinic part of the national grant for SBIRT?
No, Dr. Dwinells, the federal government SBIRT grantees have to complete a separate evaluation. So no, you wouldn't have a GIPRA.
Okay. Yeah, we didn't get a grant for this at all. This is something we just did internally. So we have no reporting requirements other than our HRSA grant, and I explained earlier about the UDS, and that's really the only reporting that we have.
Okay. And then the last comment, which I'm sure is shared by a lot of people, Dr. Shandon says he really enjoyed your talk.
Oh, thank you very much. Thank you. Thank you so much. Again, this is, I guess, like my dad's passion was eating. This is my passion. This makes a lot of sense, and I should have gone into psych probably, but I didn't. But anyway, but this is very interesting to me, and I think it's very much needed. And in my last slide here, just to finish it up, I think to me, I'm a big believer in this integrative or collaborative healthcare delivery process. It just makes so much common sense to do this. The PCMH, the patient-centered medical home, or the health home development, I think is a must because I think we can improve our coordinated healthcare delivery. I strongly encourage implementation of SBIRT at all medical practices. Again, if you can save one life, then you've lived a good life, I think. So, and then continue to encourage legislative advocacy to support screening and integrative efforts. So, I think that's it. So, that concludes my part. So, if there's any more questions, or if we ran out of time, I don't mind having questions emailed to me or call me. I'll be very glad to answer anything.
Okay. Well, thank you so much. It was very, very informative. I just have a couple short housekeeping notes to pass on. Tomorrow morning, you will receive an email from me. This is Chris, with a link to the PowerPoints, the link to this recorded webinar, and also a link to order any CEUs that we offer. I appreciate everybody's attendance. Look forward to seeing you on future webinars. So this will close the webinar today. Thank you all, and again, thank you, Dr. Dwinell.
Oh, thank you. Thanks, Chris. Thanks, Holly.
Bye-bye. Thanks.
Bye.